Hi, welcome back to your prescription for medication education. My name is Yenmi and I'm a pharmacist and I'm here to bring you quality information regarding medications and health related topics. And today's video will be about hypertension. I actually wanted to start a video on calculations, but I'm not sure how I'd be able to do that on PowerPoint. I just don't know how. So if somebody out there knows of a good program, please put a comment in my video and let me know. I don't want to film myself using a whiteboard either. I think that's kind of outdated. Anyways, let me go ahead and get started. Without getting too detailed, let's do a quick refresher of how blood pressure is regulated. Arterial blood pressure is the pressure in the arterial walls measured in millimeters of mercury. The heart, arterioles, postcapillary venules, and the kidneys are involved in maintaining blood pressure. Arterial blood pressure changes through the day following a circadian rhythm, with the highest values typically occurring in the morning. Barrel reflexes, along with humoral mechanisms at these sites, coordinate to control blood pressure. Baroreceptors provide rapid, reflexive blood pressure control over seconds by sensing stretch of blood vessels in response to increases or decreases in internal pressure. Baroreceptor activation results in decreased central sympathetic discharge, decreased heart rate, and contractility, all of which contribute to a decrease in blood pressure. The opposite occurs when baroreceptor activity is reduced. This is especially important during postural changes. When we suddenly stand up, baroreceptors sense a reduction in stretch, resulting in a reflex response, leading to disinhibition of sympathetic outflow. This sympathetic outflow acts on nerve endings to constrict arterioles and increase cardiac output to help restore normal blood pressure. The kidneys are involved in long-term blood pressure control over days to weeks by controlling blood volume, primarily through sodium and water handling and activation of the RAS system. When renal perfusion is decreased, which can occur due to many reasons such as dehydration, hemorrhage, or renal artery stenosis, this causes intrarenal redistribution of blood flow and an increase in reabsorption of sodium and water. Decreased renal perfusion also leads to sympathetic stimulation mediated by beta-1 receptors, resulting in renin secretion, initiating the RAS system. Arterial blood pressure reflects the interaction between cardiac performance and vascular tone and is primarily determined by cardiac output and total peripheral resistance. Cardiac output represents the volume of blood ejected by the heart per minute and is defined as cardiac output equals heart rate times stroke volume. Total peripheral resistance represents resistance to blood flow through the systemic circulation and can be approximated as total peripheral resistance equals mean arterial pressure minus central venous pressure over cardiac output. Mean arterial pressure represents the average arterial pressure over the cardiac cycle and reflects organ perfusion. Because approximately 2/3 of the cardiac cycle is spent in diastole, mean arterial pressure can be estimated as mean arterial pressure equals systolic blood pressure plus 2 times the diastolic blood pressure over 3. Systolic blood pressure is influenced primarily by stroke volume and arterial stiffness, whereas diastolic blood pressure is largely determined by peripheral vascular resistance. Hypertension's pathophysiology is multifactorial. Most hypertension cases is of unknown pathophysiological etiology, referred to as essential or primary hypertension, which is treated by controlling blood pressure levels. Secondary hypertension has identifiable causes that, when accurately diagnosed, can lead to actual curing of the condition. The most common causes of secondary hypertension are primary aldosteronism, renal parenchymal disease, and renal vascular disease. Other causes include obstructive sleep apnea, drug-induced hypertension, pheochromocytoma, Cushing syndrome, and thyroid disorders. There are many pathophysiological mechanisms contributing to hypertension. These include neurohumoral, vascular, renal, metabolic, and environmental mechanisms. Neurohumoral mechanisms involve increases in sympathetic nervous system activity and activation of the renin-angiotensin-aldosterone system. Angiotensin II promotes vasoconstriction, stimulates aldosterone release, enhances sympathetic outflow, and contributes to vascular remodeling and inflammation. Vascular dysfunction is another key contributor. Endothelial dysfunction and increased vascular stiffness results in deficiencies in vasodilators such as nitric oxide and prostacyclin, leading to increased peripheral vascular resistance. Oxidative stress also contributes to endothelial damage and promotes inflammation. The kidneys play a vital role in blood pressure regulation. Impairment of pressure natriuresis leads to increased sodium reabsorption, volume expansion, and elevated blood pressure. Metabolic and inflammatory factors also contribute to the development of hypertension. Obesity and insulin resistance create a state of chronic low-grade inflammation, oxidative stress, and increased production of vasoconstricting adipocytokines, which impact the RAS pathway. Environmental and genetic factors such as high sodium intake, low potassium intake, alcohol overuse, stress, sleep disturbance, and heavy metal exposure also contribute to blood pressure elevation. Normal blood pressure is defined as a blood pressure of less than 120 over 80 millimeters of mercury. Hypertension is the leading cause of death and disability worldwide, and it is defined as a blood pressure of 130 over 80 or higher, or any patient on antihypertensive therapy. In the US, the overall prevalence for hypertension in men is 49.5%, and for women, 43.9%. As we age, the prevalence for hypertension increases. For example, for both men and women between the ages of 60 to 74, the prevalence for hypertension is over 70%. Higher blood pressure is associated with an elevated risk for total cardiovascular disease, coronary heart disease, heart failure, aortic and peripheral vascular disease, kidney disease, stroke, dementia, and cognitive impairment. It's important to recognize the importance of preventing hypertension in the first place. Patients on antihypertensive medications who have blood pressure readings of less than 120 over 80 still have twice the risk of cardiovascular disease compared to patients with blood pressure readings of less than 120 over 80 without hypertension. Once blood pressure is above normal, there may be irreversible vascular damage and residual risk even after treatment is started. The American College of Cardiology and the American Heart Association's definitions for blood pressure readings are listed below. Normal blood pressure is less than 120 over 80. Elevated blood pressure is defined as systolic from 120 to 129, while diastolic remains normal. Stage 1 hypertension is defined as a systolic reading of 130 to 139, or diastolic reading of 80 to 89. Finally, stage 2 hypertension is when systolic readings are 140 and higher, or diastolic readings are 90 and above. This diagnosis is based off of at least 2 or more readings which occur on 2 or more occasions. I didn't include hypertensive emergency on here, but we'll get to that in a future video. We'll wrap up today's video with just a couple of questions. A 64-year-old woman has repeated blood pressure readings of 146 over 82. She is asymptomatic. Which estimated mean arterial pressure is most appropriate for this patient using standard clinical assumptions? The answer is Bravo. A 55-year-old woman has blood pressure readings of 132 over 84 at 2 clinic visits 1 month apart. She is not on antihypertensive therapy. How should this patient be classified according to ACC-AHA criteria? The answer is Charlie. A 62-year-old man with a history of hypertension is well controlled on medication with blood pressure readings consistently less than 120 over 80. Why does this patient still have a higher risk of cardiovascular disease compared with a never hypertensive individual? The answer is Bravo. A 67-year-old woman with long-standing hypertension presents with acute illness and sinus tachycardia. Her blood pressure is 140 over 85. Why may the standard MAP approximation overestimate true MAP in this patient? And the answer is Charlie. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and sharing my channel. Thank you. Have a great day.